joining us, but we'll go ahead and get started. So with that, good afternoon, everyone, and welcome to our very first conversation series program of the new year. My name is Deanna Fenton, and I have the pleasure of serving as a Senior Manager of Program Development and Operations here at the Alliance. Now, based on strong community feedback from a program we hosted just last year, the Alliance is pleased to be partnering with SRTR to host an annual metrics learning program for the community. That said, we will soon be welcoming John Snyder, who will provide further information about the various performance metrics that are available by SRTR, with particular focus on the new metrics that will be used by the NPSC. But before we welcome John, I'd like to take this opportunity to recognize OmniLife Health, a 2023 advocate level corporate partner of the Alliance, for their sponsorship of today's webinar. Now, OmniLife Health is setting a new standard in clinical workflow automation by connecting care teams throughout the organ transplant journey and other complex care environments. Their platform accelerates optimal health outcomes with reliable digital tools to simplify and standardize complex care and encourages purposeful collaboration across the enterprise, external partners, and patients. They help transplant centers digitize their organ intake checklists and protocols, as well as patient waitlist management to increase productivity, reduce the impact of staffing shortages, optimize performance and billing, and ultimately transplant more patients. To learn more, we encourage you to visit their website at omnilife.health. Now, as always, we want to encourage you to use this as an opportunity to engage with our presenter by submitting any questions you may have. That said, please take this opportunity to locate the chat feature that's located at the very bottom of your Zoom window. Additionally, if you happen to be using this as a group learning opportunity, we'd like to ask that you take a moment to complete the following poll to share approximately how many people have joined your group. Now, with all that said, I'd like to go ahead and get us started by welcoming our moderator, Katie McKee, who serves as the Director of Hospital Services and Donor Family Aftercare at LifeSource, and is a valued member of the Alliance's Conversation Series Work Group and National Donation Leadership Council. Katie, we so appreciate you for being with us today to help facilitate the discussion. So with that, I'll go ahead and leave it to you to get us started.
Thank you so much, Deanna. And it is my honor to introduce Dr. John Snyder, Director of Transplant Epidemiology for the Chronic Disease Research Group of the Hennepin Healthcare Research Institute in Minneapolis. John serves as Director of the Scientific Registry of Transplant Recipients, the Director of the SRTR, and in several other capacities, including Treasurer of the Board of Directors for the Alliance, the Secretary of the Board of Directors for Donate Life America, and as a member of the LifeSource Clinical Policy Board. John also serves in several statistical and associate editor roles for leading transplantation journals. His many awards include the Executive Director's Award from the Association of Organ Procurement Organizations. Today, John will walk us through an overview of the new transplant performance metrics being rolled out by the Membership and Professional Standards Committee. John will then be joined by several of his SRTR colleagues to lead 4 breakout sessions for topic-specific presentations and dialogues, and you'll hear more about these from John in just a moment. I have the privilege of serving on one of SRTR's many perspective gathering councils and continue to be inspired by John and his colleagues and the way they take a thoughtful and holistic approach to incorporating many voices in our community, working toward translating data into meaningful, actionable information to benefit patients. I would encourage you to check out a wonderful Alliance spotlight written on John by Jan Gleason, which is available on the Alliance website. And in that content, you'll learn more about John as outdoor enthusiast, avid musician, John's wonderful family, his light bulb moment in statistics class, which inspired his leadership today in healthcare, and his epidemiologist mission. So take a moment for that at some point in the near future. John, thank you so much for the many meaningful ways you lead in the community of donation and transplantation. We are really looking forward to today's session.
Well, thank you so much, Katie. That was such a generous introduction, and it's an honor to work with your team at LifeSource. Just an honor to get to know the staff and the dedicated folks there. I actually think it's it's perfect that we have a moderator from the OPO community for a webinar that's mostly focused on transplant performance metrics of the transplant programs. I think it speaks to the collaboration and the spirit of what we're all trying to do to improve the lives of the patients our system serves. And I think it also is telling of the Alliance, and my thanks to the Alliance team for hosting this webinar. I always look forward to the opportunity to participate in these webinars with the Alliance, but I think this is exactly where the Alliance really helps our community, is by bringing together various players and various teammates and various organizations within the transplant donation space to try to make this better. So it's an honor to be here. I have a team with me. You will get to know them as we go. Thinking ahead a bit, though, I just want you to be thinking about what questions you have as I go through this. We're going to share a lot of data and information, and certainly not meant to overwhelm, but to give a lot of information. And then we'll have a time, we're hoping for about a half an hour of breakout session at the end of this. And so we'll learn more about that as we go. Before I jump in, though, I do want to recognize the loss that our entire transplant community had in the past week when we lost Glenn Matsuki, who was a partner with us at the Alliance, a fantastic employee, and just did so much for the Alliance and many organizations within transplant even before that. So I do want to recognize just not only what he contributed to our field, but also just the loss of him as just for those of us who got to know Glenn, I think that it's just what a wonderful human being. And so I thought before I jump in, I just want to take a moment of silence and just recognize that loss before we jump in. Well, thank you for that. I do recognize that there is a portion of the Alliance's website devoted to recognizing his contributions. And so I encourage you to read that if you didn't happen to know Glenn as a person. All right. By way of disclosure, I do direct the SRTR. However, my views that I present today don't necessarily reflect those of Health and Human Services or any sponsorship of any organizations or commercial practices. So we'll get that out of the way. As Katie mentioned, I serve on a few board of directors and the clinical policy board at LifeSource, and participate in some editorial boards at the journals as well. So I'm happy to do that. Here are our goals as we walk through. I'm really going to focus on the new metrics that the Membership and Professional Standards Committee, or MPSC, will be using to assess transplant program performance going forward. I'll hopefully identify for you how to find and interpret the models that are used in those risk adjustment metrics, and then we will break out into breakout sessions for a deeper dive into the various aspects. And having said that, we are going to launch a poll so that we can efficiently move you into breakout rooms at the conclusion of my presentation. And these are the 4 groups and our SRTR lead that will be leading them. And so if you could just choose from the poll here, which one you think you will go into, that would be an excellent thing to help us facilitate that at the end as we move forward. And I'll just ask Deanna at the Alliance if you want me to move on, or should we wait for people to fill in the poll here, and we will go.
You can feel free to move on, John. I'll leave it open for folks to continue responding as we.
Excellent. Great. As you're choosing, we've split up the breakout groups into offer acceptance metrics, pre-transplant mortality, post-transplant graft failure, and then the risk adjustment models themselves. I'll talk a bit there about more in depth about how we build them and be able to answer some questions, I hope. Great. Well, let's first cover some history here. So first-year patient and graft survival have been the primary metric to monitor program performance all the way back since 1987. This has been criticized over the years, and particularly recently, as an overemphasis on post-transplant outcomes. People recognize that the transplant process is way more complex. We've certainly been moving in that direction at the SRTR to better understand and better create a holistic view of the transplant experience, particularly for patients. So what happened in 2019, the OPTN formed an ad hoc systems performance committee And that committee took up the issue about how we should be monitoring system performance. They made a recommendation to the OPTN board that we take a more holistic approach to the evaluation of transplant hospital performance. And they put forward this idea of developing a balanced scorecard. Now, that balanced scorecard idea means different things, I think, to different people, but the spirit of what they were suggesting was that we balance looking at what happens in the pre-transplant era with what happens post-transplant, and just kind of look across all aspects of care as best we can. So what happened then thereafter in 2020, the MPSC formed the Performance Monitoring Enhancement Subcommittee to make recommendations about how we should fulfill that recommendation to the board. SRTR, of course, works with the MPSC in all of the metrics that they are evaluating. And so we partnered with them to develop and explore these new metrics and decision rules. I'll talk more about that as we go as well. Those were proposed and passed by the OPTN board in December of 2021. And the 4 new metrics are shown here. There are 2 on the pre-transplant side and 2 on the post-transplant side. For pre-transplant, we have the waiting list mortality rate ratio, or pre-transplant mortality rate ratio. We have offer acceptance rate ratio, 90-day graft failure rate ratio, and conditional 1-year graft failure rate ratio. Not to be repetitive, but one thing you'll notice in all of these, they all end with the phrase rate ratio. And that is essentially to indicate that these are all risk-adjusted metrics. They compare, in some sense, an observed event count to an expected event count after we do risk adjustment for the types of patients either on your list, or the types of patients you transplant, or the types of offers that you are receiving. All of these, the MPSC felt was an important aspect of this, was to be able to risk adjust so that we can, as best we can, compare apples to apples across the programs. So, we say these are the new metrics that the MPSC is looking at. Just pulled a quote it's hard to find an attribution to this quote. Everything old is new again. Just point out that most of these have been reported by the SRTR in some fashion for a long time. Pre-transplant waitlist mortality rate ratio has been reported publicly since 2000. The offer acceptance rate ratio, a little more recent, but we have had those in the public reports since 2017. The 90-day graft failure and conditional 1-year graft failure, those are new in terms of the split, and I'll talk more about the split there. But historically, the full first year has been evaluated all the way back into the late 1990s. And so most of these data shouldn't be, quote unquote, new to the community. We have had those in the reports for some time. What's new about them, though, is the MPSC is looking at them either for the first time for the pre-transplant, the 2 at the top, or in a slightly different way, carving out that 90-day and conditional 1-year graft failure rate. So I'm not sure if Jonathan Swift said that, or Winston Churchill, or Mark Twain, or somebody else, but that quote came to mind when I was thinking about new metrics. This is something that we have worked hard with the MPSC to make sure we follow, is this suggested order of operations. And the first step is always to be clear about who is looking at these metrics and why. We can't decide what the best metric is in number 2 until we're very clear about what the purpose is for evaluating any metric. And then finally, and lastly, for the MPSC's purpose, if we have to have a screening test or a flagging rule, we need to do that last. I sometimes hear people criticize a metric because it flags too many programs. And I like to remind folks that the flagging rule is really a separate component of the metric. We can design a system that flags as many or as few programs as the community wishes. There will always be false positives and false negatives. Any flagging rule can't be perfect. But that doesn't mean that the underlying metric itself is something that's not worth looking at. So I always try to separate out number 2 and number 3, but we have to start with number 1. Who is looking and why? Because perspective matters. Everybody can be looking at the transplant system or the donation system from their own perspective, and they will conclude that it is something different. So we have to try to get our head around who is looking at this and why. And here's just 4 simple examples. There are many others, obviously, but transplant programs, which probably the bulk of the folks listening today, are trying to decide when they're looking at data how they need to change their processes, if at all, to improve quality in their patient outcomes. Patients might be looking at these metrics to decide where they want to seek care or to better understand what their process might look like at the center they are at. Insurers, of course, are consumers of these metrics. They decide which programs to place on their list of preferred programs. And finally, what we're really focusing on today is this last box, the regulators, which in our case here is the MPSC, that are deciding which programs should be reviewed for patient safety or performance improvement issues. And so, defining this right up front matters. The MPSC's goals will lead them to the best choice of metrics for their efforts. And I'll just illustrate that a little bit for you, because now that we're clear, at least in this perspective of this talk, we're talking about the MPSC's perspective here, and then they will choose the best metrics to meet their goals. Well, how do you go about that? If you've seen my talks lately, I show this slide a lot. I'm not going to apologize for that. I think it's so important for us to understand that some metrics are better for some purposes than others, okay? And this rubric here is meant to show, in the green columns across from left to right are the phases of transplant, from pre-listing all the way to long-term outcomes post-transplant. And the metrics at the top in the purplish zone are what I'm labeling system performance metrics. And at the bottom, I'm labeling these program or OPO performance metrics. And the obvious distinction between them is those metrics at the top cut across multiple areas of the process, whereas those at the bottom are more solely within one of the green columns. I mean, we could argue some of those, but generally these are more within one specific realm of the process. And therefore, they're more directly under the control of the program themselves. Well, why does this matter? If we consider overall survival from listing, I actually, when I talk to patients and they ask me, what if I had to pick one metric to understand what's going to happen, or likely outcomes at different programs, I think overall survival from listing is a pretty informative metric because it encompasses lots of things, right? It encompasses, am I going to be alive and healthy while I'm on the wait list? Are there donors that are made available readily in my area? Does my center accept those offers for the reasonable offers for our patients on the list? Do they have good early post-transplant outcomes and good post-transplant outcomes? Those are the arrows below here that are pointing up. In other words, all of those things that I just mentioned can make overall survival from the time of listing better or worse for a patient. Now, from a patient's perspective, if it was a patient choosing a metric, I think that they don't necessarily they don't need to understand where the issue is below. They're just looking to say, what's my overall chance of survival if I'm listed here at this program? And all of those things below will influence that. So it's a good program. It's a good metric for patients to consider. But I would say this is not a metric that the regulators should consider, because it's precisely because all of these things below it influence it. So it's very difficult to understand by looking at that metric where the issue lies. And so early on in the MPSC's debate, they focused on these metrics at the bottom. That's not to say that those metrics above are not something worth looking at. But remember, the MPSC needs to sort of laser focus in on what their role is. And their role is trying to find ways to improve the system by helping the centers and the OPOs improve. And so they quickly started looking at the bottom, and they chose these 4. They thought that these 4 covered aspects of the performance that they could readily work with and identify and work with programs to improve. And they chose them for these reasons. These are the MPSC's words, not mine. They wrote in their document when they were passing these through the board that these are all measures that measure aspects of care that are clearly within the authority of the OPTN to monitor. An example of one that wasn't clearly within the authority of the OPTN was pre-transplant. If we looked at, say, listing rates at the programs, how many patients are being evaluated but then not listed. A, we don't have data in the OPTN yet, and B, it wasn't clear that that is something within the authority of the OPTN to monitor, so they stayed away from metrics like that. Or overall survival from the time of end-stage organ failure diagnosis. I think that's also a great metric for a patient if we can create something like that. But also not clearly within the authority of the OPTN. So the ones they picked, they felt were clearly within their authority to monitor and help with. Number two, it measures aspects of care that the transplant program can impact. And number three, it has a clear desired outcome. That one sounds a bit ridiculous on its face, right? It has a clear desired outcome. But I think an example of one that a measure that we can actually produce that doesn't have a clear desired outcome, I'll give you two examples. One they considered was the fraction of their program's wait list that is active at any given point in time. And once you start thinking about that, you say, well, we can tabulate that, we can calculate that metric, we can even create an O to E for that. We can do risk adjustment and say, do they have a higher expected rates of inactivity on their list or lower than expected. But when it comes down to it, it's unclear if higher is better or lower is better. Centers that do a better job of keeping track of patients on their list may indeed have a higher rate of inactivity, but that's because they're really good at keeping track of their patients and knowing which ones are suitable for transplant at any given moment. And they may inactivate others, whereas another program might have 100% inactivity, but then be wasting time in the system by entertaining offers that they're not ready for. So a measure like that is one that doesn't have a clear which direction is good or bad. Another one on the OPO side, for example, is the fraction of donors that are DCD. I think that's something we all like to look at from time to time, and we want more DCD donors. But you can get a better fraction of that by reducing your brain dead donor population. And so metrics like that don't necessarily have a good, bad direction to them, whereas they felt the ones we were looking at here, it's obvious that which direction you want that metric to move. All right, I'm going to walk through a few of these. I'm not going to go into great detail because we will have time in the breakout groups to really dig in a bit more in each of these, but just give you some thoughts from my perspective as a transplant program quality person. How do I think about these metrics? And I always say in my mind, there's three steps that you should go through. One is know where you stand as a program. Number two is know where to focus. And number three is do your best to understand the risk adjustment. Now, I'm not saying everybody has to be a statistician or epidemiologist. I'm fortunate to have brilliant ones on my team, and you will get to meet some of those later today. But I think at least having a high level knowledge of where you can find the information and generally what it means is helpful. So I'll walk through that a little bit here. So looking at the pre-transplant waitlist mortality rate ratio, just to start, what's happening here, and this is going to be a general theme across all of the metrics, we're always comparing an observed event count, in this case deaths, after you're listed, but before transplant, to expected deaths, okay? And that expected is derived from the models that we developed through that risk adjustment process, which we'll talk about. And so I'm going to use these abbreviations, O and E. O is observed deaths, and E is expected deaths. And essentially the calculation that we're using to derive what we call a hazard ratio. I'm not going to get into Bayesian statistics today, but this is what we're doing here, applying this shrinkage estimator, it's called, and we're simply adding 2 to both of those numbers and then dividing. So sometimes I have people email me and say, well, I have an O of 5 and an expected of 2, for, that's extreme, I guess, as an example. But, if I divide those 2, I don't get the answer that is your waitlist mortality rate ratio. And I remind people that you have to add 2 to both of those and then divide. And I'll give you some examples there. So let's walk through my steps. As I said, step 1, Well, it's always helpful, I think. I didn't talk about my pyramid of metrics today, but many of you have probably seen that. But the top of my pyramid is having a goal in mind. Why am I looking at data as a transplant program professional? Well, in this case, I'm hopefully able to lower the mortality rate for patients that are on my list. And the first part of that process is knowing where you stand. And I'm going to pick on our program where the SRTR is located in Minneapolis here. This is all public data. So the program here is Hennepin County Medical Center in Minneapolis. And so that's going to be the blue dot here. And other centers are in the orange. And this is how we display currently the pre-transplant mortality rate ratio estimate. And just a few words about how this plot works. From left to right is essentially how big your list is, right? So bigger programs are to the right, smaller programs to the left. And we measure that in these cases because these are rates as person years. So how many person years did we observe on your list for these metrics? And then on the y-axis, we have the estimated mortality rate ratio. Remember, these are a comparison of observed to expected. So 1.0 means you're right at what we would expect to see given the types of patients on your list. Higher is higher than expected. So a 2 would be double the death rate than we expect. And a 0.5 would be half the death rate we expect. So lower is better in this case, and higher is worse. Knowing where you stand, though, so I can tell right off the bat here that MNHC is kind of in the middle, a little bit higher than 1, so a little bit higher waitlist mortality rate than we'd expect. And this is a kidney program in this example. So what do I do with that? I'm not suggesting in this case, here's the actual numbers behind that. So we observed 772 patients for a certain number of person years. I didn't include the person years on the table here, but there were 31 deaths observed in this period of time, and we expected 26.33. And if you add 2 to those two numbers, remember, add 2 to both and then divide, you will get the overall waitlist mortality rate ratio of 1.16. And so this is just, this first step is knowing where to focus. And my conclusion here, what does 1.16 mean? So in English terms, this is basically 16% higher mortality rate than we'd expect for patients on our list. Now, that's not too extreme. You saw in the orange plot before, you're kind of in the middle of the pack. But if I wanted to do something as a quality professional to impact that, I need to know where to look, right? And so maybe one thought is, maybe my older candidates are more likely to die, so I should pull back on listing older candidates. Well, you can actually use our tools that we'll talk about in our breakout group to dig in and see if that's the case. We do give you stratifications by age within the tools that we provide to you. If I look at this program's candidates that are listed over the age of 60, you can see that their observed of 10 and their expected of 9.88 is pretty much exactly what we would expect, right? Almost exactly 1.0. So it doesn't appear to me at first glance that it's just because I'm, have these older patients on my list, that's where my trouble is coming from. Remember, we adjust for age. So just listing older patients is not always the answer to elevated mortality rates for patients on your list. Well, what about the young patients? This program had 170 patients under the age of 40, and they observed 2 deaths, and we expected almost 3. So their waitlist mortality rate ratio there is actually better than expected. So that doesn't appear to be where the issue is coming from. But if I look at the in-between, we had 19 observed deaths in those middle-aged folks, and we expected 13. So that does appear to be where the elevation occurs. Now, obviously, this is a simplified example. We don't know what's going on in those patients, but if I was going to focus in on where we saw some deaths that perhaps we didn't expect, this, I think, would be where I would start, sort of looking at these patients in this group here and seeing for those deaths that occurred, if I can learn anything and take that away. So this is the way that looks within the worksheets that we give you. And if you go into the pre-transplant mortality breakout at the end, you'll have a chance to dig into this a little bit. But this is the example where we do give you a pre-canned cut, at least in the kidney workbooks, for age splits like this. So I said that step 4 was understanding risk adjustment. We do have tools on our website that show you everything that's in the model. This element list here to the right is just a very small subset of what's in the waitlist mortality rate model for kidney currently. And we'll go into this more if you come to my session later on the risk adjustment models. But under tools, you will find all of these models here. There's nice little handy interactive tools that you can look and see what's included. And they all look like this. The model elements, there's 5 tabs across the top. And the model elements tell you what we're adjusting for. So it's simply just a listing. The source column here to the right is where in the UNet system within the OPTN data collection system these are located. You can find additional information about that under the additional info tab at the top right, but we like to point people to where we're finding these values. This is obviously a waitlist model, so most of these elements are coming from the transplant candidate registration form or the TCR form. So again, this model elements table is simply what are we adjusting for, right? So you can just get a sense of what we're taking into account when we're assessing your patients. There's a model element plot tab. I'm going to back up. So it's the one in the middle here, the model element plots at the top. If you go there, that gives you a nice little tool that allows you to visualize the risk adjustment for each of these factors. So you can pull up any one you would like, and it actually draws you a little plot of how the risk adjustment works. Now, you don't have to be a statistician. I'll just give you a few concepts to think about here. I pulled up the plot for candidate age at listing. And so this is just showing across the range in the adult model for adult waitlist mortality. So we're running from about 18 up to 75-ish on this plot. The hazard ratio is showing how the risk adjustment works. And so what you notice right off the bat is as you get older, the line goes up, all right? So that's saying that we are anticipating higher failure rates or higher death rates in older candidates, right? It seems obvious. I think this is a good example to start with. But how do I further interpret that? Well, the way you interpret this risk adjustment is, say you want to compare the expected mortality rate in a 65-year-old candidate versus a 25-year-old candidate on your list. If you want to understand, well, how much more risk does the SRTR anticipate here? It turns out if you just find where those points are on the plot, if you hover over them, it will tell you the value, and then you just divide the two. And in this case, you get 2.3. And so essentially what this means is the SRTR believes that a 65-year-old has a death rate 2.3 times higher than a 25-year-old on your list. And so we're expecting for, say, if you had 100 candidates over the age at 65 and 100 candidates at age 25, we'd expect 2.3 times more to die in the 65-year-old group than the 25-year-old group. And you can do that for any point along the way, but it's just understanding, how to interpret that, I think, is useful. Now, I had somebody ask me, does the SRTR make these lines up, or how are these derived? We analyze the full national data set for every time we do the evaluations. And so this is the national experience based on candidate age. This is not a number the SRTR makes up. This is what actually is expected nationally across the range of candidate age. So this adjusts every 6 months when we adjust the models. We keep this current. So this is actually describing national experience today. And this is an example of what we would call a categorical risk adjuster variable, which means it's just categories of things. It's not a continuous line like age. And this is an example of diabetes type for your candidates. And shown here is the hazard ratio for type 1 diabetics. And you can do the same thing, right? So the hazard ratio that's shown 1.26, that's versus the 1 line. So the type 2 diabetics, for example, are on the 1 line, and the unknown diabetes is on the 1 line. So relative to them, we are expecting a 26% higher death rate. But if you divided that number for type 1s versus the non-diabetics over here, that would give you the risk that we're expecting for a type 1 diabetic versus a non-diabetic. So it's helpful to just understand what we're adjusting for there. In this case, if I do that math, we're getting that 1.77 if we just divide those two numbers. So that tells us that type 1 diabetics nationally are 77%, they have a higher risk of death, that's 77% higher than non-diabetics. Okay, so we're on to step 3. I'm going to touch on the MPSC's flagging rule. MPSC has already chosen the metrics that they believe would best meet their goals in step 2, and then they need to have a flagging rule. The MPSC, if they had unlimited resources, could just work with every program in the country and help them improve if there's areas they can improve. But they don't have unlimited resources, so they want to develop a rule to look at the programs that are the ones that have the most evidence of needing assistance or being out of the norm. I like to point people to this nice paper by Christensen and Morris. This dates back to 1997. And essentially is a really well-written explanation of what we're doing here. They were writing more generally for just hospital evaluation on any metric. But this is exactly what we're doing in transplant. So we develop these bell-shaped curves for every transplant program. And then we're having to decide 2 things, so how far. This example in the plot is a mortality rate, just a fictional mortality rate for 3 hospitals, H1, H2, and H3. And the bell-shaped curves describe how certain we are of where we believe their mortality rate ratio to be. And so in this example, the more to the right these bell-shaped curves are, the higher their projected mortality rate, and more to the left, the lower. And the 2 vertical lines here are essentially showing the one on the left is the population average. And then the one on the right is a cutoff. And this is a place that's like the MPSC flag boundary, right? You basically have to make a rule that says which of the hospitals are too far to the right of this cutoff, okay? That's how these flag rules work. You can define a probability, right? So you can actually mathematically calculate how far to the right each of those curves are from the cutoff point. And then if it's too far, based on, say, having a probability or an area under that curve to the right that's higher than some cutoff, you can actually say those are the programs we want to flag. This is exactly what's happening in the MPSC rules. We're using this process. We start with a prior belief, and then we observe your program's data, and that converts this bell-shaped curve into a new bell-shaped curve. We call it a posterior belief. I'm not going to get into the details of the Bayesian statistics methodology being used here, but this is essentially what's happening. We develop these bell-shaped curves, and then we have to ask ourselves, how far to the right of some cutoff are they? And this is the rule that the MPSC came up with for the pre-transplant mortality rate. And this is exactly the same rule that they use for the post-transplant graft failure rates as well. And that is that cutoff they chose is the second number here, 1.75. So they're saying once a program's mortality rate is past that 1.75 range, and that is to say 75% higher than we'd expect, that's the zone where the MPSC is concerned enough that they want to at least take a look. But there's another number here, greater than 50%. That is like how much of the curve is to the right of that cutoff. And so we're saying that we need at least 50% of that bell-shaped curve to the right of 1.75. That is to say, we are at least 50% certain in our evaluation that their mortality rate is that high or higher. Those are the programs that we would review by the MPSC, and that allows us to draw a boundary like this. This is exactly what the mortality rate evaluation looks like for the MPSC currently when they developed the rule. Each of the dots here is a transplant program's waitlist mortality rate ratio. And I'm only showing you the upper half of the plot. It starts at 1 on the y-axis. That's because programs with elevated mortality rates are the ones that the MPSC is interested in. So just for clarity here, I've zoomed in on those that are higher than 1. And then when we define that boundary to say that the dots in the purple zone are those that have at least a 50% probability of being higher than 1.75. And you'll notice that most of those are up around about 2 in their hazard ratio. That's because to have greater than 50%, we need the top of that bell-shaped curve to be to the right. So generally, that means that most of these dots are going to have almost twofold the failure rate as the dots that aren't in that flag boundary. So generally, the MPSC is concerned with programs under this rule that have almost double the waitlist mortality deaths that we would expect. So let's think back to this example. This was exactly the example I started with. Here's the calculation again. I add 2 to the observed and the expected, and I get that ratio of 1.16. This is the MPSC evaluation rubric here, right? So they have a yellow zone and a red zone. The yellow zone is that we have 50% probability that they're greater than 1.5, and the red zone is 50% probability that they're greater than 1.75. This picture here is what we look like before we even observe the data. So we believe before we look at the program that their hazard ratio is somewhere in here, right? So it's somewhere in this bell-shaped curve. And then we look at the data and we recalculate, and this is exactly what this one looks like. So the middle of that bell-shaped curve is at 1.16. That's the blue line. And then we can put those cutoff values on the curve, the yellow zone and the red zone, and we can calculate how much of the curve is to the right of those points. And in this example, we had 5.8% in the yellow zone and 0.5% in the red zone. Those numbers need to be above 50% in order to be flagged by the MPSC. Obviously, this program, even with hazard ratio 1.16, which is slightly higher than expected, is really nowhere near the MPSC flagging zone. So this program is safe from their review, if you will. Well, what would happen if this program had 8 more deaths? Okay, so instead of the 32 that were observed, what if they had 40 and we still expected only 26? Well, here you can see what happens. The curve shifts a little bit to the right. I'll bounce back. This is what they really were. If they would have had 8 more deaths, that curve moves to the right. Now we have 45% probability of being in the yellow zone and 12 of being in the red zone. So still not flagged, okay? But what if they had 17 more deaths? Okay, they had to have 48 deaths and 26 expected. That would put them into the red zone. That shifts this bell-shaped curve even to the farther to the right. And now they have 50.5% probability that this curve is to the right of 1.75, which is enough for the MPSC to start doing a review of this program. So again, 17 more deaths, unlikely, but just an illustration of what it would have taken for that program to be flagged. All right, I'm not going to go into more depth. I want us to get to our breakouts, but the other measures, I'll say a few things about them. They work the same. They all have this O to E, and we add 2 to each and divide. You still can go through the same process. This is the offer acceptance rate ratio. This is our program here in Minneapolis again. They have a slightly lower than expected acceptance rate for kidney offers. Knowing where you stand, we can compare that to where they would fit within the national distribution here shown in the box, which is about average, but slightly lower. And on our secure site, we provide a breakdown of different categories of offers. And so overall, this is a different program here that I've blinded for the sake of our example here. This is not our program in Minneapolis anymore, but we give an overall evaluation. This program had about half the rate, the offer acceptance ratio in the upper right corner overall. And you can look within categories of kidney donor risk index, low, medium, and high KDPI, if you will. And you can see that they have pretty much their lowest acceptance probability is among those high risk, high KDPI offers. They have about half the rate of DCD donor acceptance that we would expect. We also provide a weekend effect. So these are offers that your program receives on Friday or Saturday. This is, I think, useful for programs to understand their processes to see if they have a dip on the weekend relative to what we would expect to be happening on the weekend. These data are provided on the secure site and are not part of the public report, although some of those subcategories are shown in the public report. The screening rule here is slightly different than the other 3 measures. We need a 50% probability the program's offer acceptance rate ratio is less than 0.3. Remember that on this one, lower is the direction that the MPSC is interested in evaluating. So if you have a very low acceptance rate, they're trying to understand if we can improve that process so that we can get these offers to programs that will accept them in a more timely manner. So when you visualize that screening rule, it looks like this. So those in the purple zone are the programs that the MPSC would be investigating. Less than 0.3 means that their acceptance rate is at least 70% lower than we would expect based on the types of offers they're receiving. Again, we show the risk adjustment models here on our website at that same location I showed you, and we'll talk more about these. We do have QSUM charts available for these as well. These are statistical monitoring charts on your secure site that show you when your program maybe has a change in your offer acceptance practice. If the line shoots up and hits the red line, that means we have enough evidence to suggest that something changed at your program and you stopped accepting offers at that time. It's a pretty sensitive chart. There's a lot of offers that programs receive, and so you can track your performance over time. And then just a few slides on the 90-day conditional 1 year. As I said at the onset, we've been evaluating first-year graft failure for over 20 years in this country. What the MPSC is doing now is simply splitting that into separate categories. First 90 days post-transplant versus the conditional 1 year. And the reason that the MPSC was interested in doing this is they recognize that there's an early post-transplant failure rate that's elevated. And the committee had discussions about, well, you know, initially post-transplant, it's the surgical care, it's the immediate post-op care. And then once the patient is discharged, it's really a different process of care that starts to happen. You know, maybe in kidney, for example, you're going back to community nephrologist or some such. And so that day 90 beyond is meant to capture that 1 year once those failure rates have stabilized. And so the MPSC recognized there are two different processes happening there in that post-transplant period, and that drove them to this split. I am going to wrap up here so we can get to our breakouts, but I do want to point you to a couple webinars that are available on our website. We do have risk adjustment model webinar and a tools webinar that I think are very helpful in terms of walking you through some of the tools that we have on the website. So I would point you to those. We do have a YouTube channel, and you should be able to find those webinars on our website as well. So at that time, I will turn back to Katie for any wrap up that you would want to make, and then we will head into our breakouts.